Dr. Coluzzi, Flaminia, welcome. We are very eager to listen to your talk.
Good afternoon. It's a pleasure for me to be part of this special panel for this section this afternoon. These are my disclosures. I will try in the next few minutes to give you some important information about what I think it's important to do and what to don't when treating patients with chronic pain suffering from multiple myeloma. And I would start soon with this message. First of all, use a mechanism-based approach to pain. Why I believe this is the first message for you. Few years ago, all the different kinds of pain in patients with multiple myeloma. And we realized that analgesia is in the middle of a number of different possible treatments like radiotherapy, surgery, chemotherapy, or other treatment like target therapy, like biphosphonates and steroids. But bone metastases are not the only kind of pain in these patients. And this slide has been shown previously. And we want to summarize in this picture the idea that myeloma bone disease is often the onset symptom for this patient. However, along all the natural history of this disease, a patient may suffering from different forms of chronic pain, including peripheral neuropathy, or, for example, postherpetic neuralgia because of immunosuppression increase the risk of infectious disease. Alongside the pain chronification, the kind of pain in this patient move from nociceptive pain to a neuropathic pain. So it's very important to consider not only intensity of pain, but also which kind of patient is suffering in order to select the right drugs in our patient. The neuropathic pain component in mixed pain syndrome, it's important because it's typical of a situation when there is a lesion of peripheral nerve or central nervous system, and in particular there is the absence of external potentially noxious inputs. And this is typical of two situations, the neuropathic pain and the nociplastic pain, where the peripheral and central nerves are absolutely normal. However, patients suffer from this specific kind of pain that it's called maladaptive pain, because there is no reason for feeling pain if you don't have any potentially noxious stimulus. The second message is treat pain aggressively. Why? Because very often physicians still use this old WHO analgesic ladder as a scheme for treatment of myeloma bone disease. However, nowadays, you should consider that this ladder was introduced with the only aim to improve the use of opioids, in particular in some countries where the opioids are completely absent from the clinical use. And the fourth step was introduced as an alternative when in patient not responding to the third step with the strong opioids. It's clear that it's something very old. Nowadays, you should think about a lift, and you select which step is the right one for your patient. Myeloma is the classical example that I always do, where the patient very often start from the top of the ladder. So when the bone fracture is the onset symptom of the disease, you start with strong analgesics. You may propose invasive treatment if it's indicated, and if the patient answers to treatment, you can reduce the amount of drug you are using. You can change the step and move in a lower step if the analgesia is enough, but you cannot wait all the single steps in order to arrive to the place that is the right treatment for your patient. The other indication is prefer a tailored therapy. We have a number of different opioids, how to choose. First of all, you have to understand the different kinetics. We have long-acting opioids, which are the most indicated in background pain. You have a short-acting that should be used mainly in the titration together with long-acting in order to select the right dose for your patient. And the rapid onset that should be used only for breakthrough cancer pain. In the titration, which is the most important step in order to reach the lowest effective dose, you must start low and go slow in order to minimize side effects. However, you should know that very often there is an overlapping between optimal analgesia and side effect profile, in particular for traditional strong opioids. Other consideration, very often physicians select the opioid according to his own familiarity. We do not consider patient preference. Do you want a transdermal patch or you don't? Tolerability profile, efficacy, pharmacokinetics, and patient characteristics. An example which is very useful, in particular in myeloma, is the patient with the renal disease. You always have to consider creatinine clearance by measuring, even with the formula. If the number that you obtain is lower than 30, please use only buprenorphine patch and fentanyl patch. With the starting dosage for buprenorphine, we have very low dosages. That means 5 micrograms per hour with the 7 days patch, or fentanyl patch, starting dosage 12 micrograms per hour. All the other opioids are not recommended, in particular morphine and codeine. On the other side, if you have a patient with the hepatic impairment, you should know that, for example, fentanyl is metabolized in the liver for 90%. Therefore, it's not recommended in this kind of patient. Oxycodone should be used with caution. And tramadol and codeine are not recommended in patients with severe hepatic dysfunction. Other information are related to the risk of drug-drug interaction. In this pie chart, you can see on your left the number of drugs in the market metabolized by the isoenzyme 2D6 and 3A4, which represent, as you can see, about 75% of drugs on the market. On the right, you can see the total amount of these isoenzymes in our liver. It's clear that if you use together many different drugs metabolized by the 2D6, the risk of interaction becomes very, very high. Which information we have about opioids? As you can see in these slides, most of our opioids has a phase 1 metabolism. That means that cytochrome 2d6 and 4 are relevant for metabolism of these drugs. And there is also a genetic variability in the expression of these isoenzymes. The only two in these slides that you can see with the phase 2 metabolism is hydromorphone and morphine. However, we know that there are at least 4 opioids with a cytochrome P453 metabolism, which are morphine, hydromorphone, oxymorphone, and tapentadol. In particular, we had an experience with the tapentadol in multiple myeloma, and we published this paper a few years ago. Tapentadol is different from the other traditional opioids because it is an agonist of mu-opioid receptor, but it's also inhibitor of reuptake of noradrenaline. And this is the reason why we suppose that in patients with myeloma bone disease, where, as you can see in this graph, there is an important percentage of patients with a neuropathic component as measured by the DN4, we observe a reduction in P intensity since the first week of treatment and a significant reduction in the neuropathic component of pain. The other message is please prevent chronification. Prevent chronification means please start treating pain early. Don't wait. There is an interesting paper which has been published a few months ago, which showed that after stem cell transplantation, 50% of patients continue to use the same amount of opioids, but incredible, 22.7 increase the dose after transplantation. What's the reason? Well, probably is the inadequate pain relief at the beginning of the myeloma bone disease. And if you don't treat aggressively pain at the beginning of the disease, the risk of chronification, which means a neuroplasticity in the central nervous system, led to persistent opioid use. The other message is that for breakthrough cancer pain, you always have to use rapid onset of opioids. Breakthrough cancer pain is typical in patients using opioids. You need to have a patient with a background pain treated with at least 60 milligrams of morphine, with a good pain relief along the day, except for no more than 4 episodes of breakthrough cancer pain during the day. And in this case, rapid onset, because of the short onset, but also the short duration of action, are the right drug to be administered. As you can see in this picture, when you treat this patient with the rapid onset, you cover exactly the dynamic of a breakthrough cancer pain episode. And this is the reason why you cannot use oral morphine or oral oxycodone. These are immediate release drugs, and the onset is over 30 minutes, which is too much. My time is precious. Don't waste time. I need transmucosal fentanyl, because fentanyl is a very lipophilic drug. Honestly, buprenorphine would be the most lipophilic opioid, but is less potent than fentanyl. And this is the reason why all intranasal or transmucosal formulation are fentanyl-based. How can you choose? Well, there are only few situations where you cannot use transmucosal. For example, if you have a strong xerostomy or nausea and vomiting or severe mucositis. On the other side, you cannot use a nasal spray if you have a nasal pathology, if the patient using vasoconstrictors. But all the other situation, probably is the patient who should decide which formulation is better for his needs. What you don't have to do. First of all, do not consider opioids if you have a patient with a neuropathic pain condition. We listened in previous lecture many different reasons why myeloma patient may have neuropathic pain condition, like from bortezomib with the classical socks and gloves distribution, or bone disease, or after herpes zoster virus. Well, according to the guideline, gabapentin and pregabalin are the first-line drugs in this condition. However, if you look at the number need to treat, it's not very short. It's up to 7, which means that you need to treat 7 patients in order to have at least 1 patient with 50% pain relief. Instead, if you look at strong opioids and tramadol, the number is significantly lower. However, the reason why gabapentinoids are the first line, because they work on the alpha-2 delta subunits of a calcium channel. They prevent the income of calcium in the presynaptic terminal, and they reduce the release of neurotransmitters. However, the third line for opioids, it's only related to the risk of abuse. And this is the reason why when we have to use an opioid because the gabapentinoid or the antidepressant, it's not enough for neuropathic pain condition, we prefer tapentadol for its activity on mixed pain. And tapentadol introduced the concept of mu load, which means that in order to obtain good results in nociceptive pain, the amount of activity on the mu opioid receptor is 54%, but is reduced to 36% in neuropathic pain condition. And finally, do not forget opioid-induced adverse events. In particular, I focus only on opioid-induced constipation. First of all, because we don't have so much time, but secondly, because it is one of the side effects which does not undergo tolerance, which means that you can have opioid-induced constipation since the beginning along all the treatment with opioids because of the presence of a mu opioid receptor in the gastrointestinal tract. And one of the solutions is the association between oxycodone and naloxone, because naloxone, when is administered by the oral route of administration, undergoes a wide first pass hepatic metabolism, and the bioavailability is only 2%. And this is the reason why it does not affect the analgesic activity of oxycodone. However, it's a fixed combination, so I can use only together with this kind of opioids. And this is the reason why in the last few years has been introduced PAMORA, which means peripherally acting mu opioid receptor antagonist, which works only on a mu opioid receptor in the gastrointestinal tracts because they do not cross the blood-brain barrier. As you can see in this table, we have one formulation subcutaneous, which is methylnaltrexone, and the two most used are oral formulation, naloxegol and naldemedin. Naloxegol is a derivative of naloxone with a long polyethylene glycol tail, which makes this molecule a substrate of a pig glycoprotein, and this is the reason why it doesn't pass through the blood-brain barrier. And finally, naldemedin, which is the last one introduced in the market, which is effective not only for opioid-induced constipation, but also for nausea and vomiting, and is a drug which is an analog of naltrexone, and for the same reason, as you can see in the red circle, there is a tail which prevent the passage through the blood-brain barrier and prevent the impact on the analgesia of co-administrated opioids. In conclusion, probably we do not have the perfect drug for all our patients, but the main message that I want to leave you is please do not consider only the intensity of pain, but your approach should be mechanism-based in order to obtain the best results in your patient. Thank you very much.
Thank you very much, Flaminia, for really another superb talk. And it's an art, actually. It's not only about pharmacology. It's really an art, but it's worth to spend some time to really understand the way we should handle and prescribe these painkillers.